Hi, so welcome to my presentation. And at the Royal Wolverhampton Trust, a single large UK centre, we're conducting a 12-month longitudinal study exploring the impact of COVID-19 on patients with rheumatic disease. And here we're presenting the initial findings assessing the impact of COVID on health-related quality of life scores in patients with rheumatic disease. So worldwide, the detrimental consequences of the COVID-19 pandemic on physical and psychological health have been recognised, with the pandemic being associated with significant levels of psychological distress in the general population, affecting both those with and without the COVID infection. And significant numbers of patients with rheumatic disease are classed as clinically extremely vulnerable, as defined by UK national guidance. And those falling into the clinically extremely vulnerable group follow extra precautionary measures. And these extra precautionary measures include stringent social distancing, termed shielding. And shielding is implemented at times when the infectivity rate of COVID in the general population is high. And shielding rules require that patients remain isolated in their homes, having minimal contact with others. And during the first wave of the pandemic in the UK, shielding rules were put in place for a minimum of 12 weeks, starting from the 23rd of March 2020. And during this wave, shielding rules didn't end until the 1st of August 2020. And lockdown measures were then reintroduced at the end of October 2020 and put in place for a further 4 weeks during the second wave in the UK. And it's recognised that shielding measures in this group adversely impact these patients' mental health. And evidence in this group highlights the importance of physical activity in maintaining physical and psychological well-being. Even prior to the pandemic, limitations in both physical functioning and mental health in these patients were recognised. And this interim analysis of an ongoing study seeks to explore the impact of COVID-19 on the physical and psychological well-being of patients with rheumatic disease to inform guidelines and target service provision moving forward during the pandemic and beyond. So to conduct our study, we distributed 2 web-based surveys 8 months apart during the first and second wave of the pandemic. And surveys were piloted with 2 patient participation groups, a national charity, clinicians and rheumatology nurse specialists. We contacted and distributed surveys to all rheumatology patients under active follow-up at the Royal Wolverhampton Trust with a validated mobile telephone number. And we distributed surveys via SMS message containing a web link to the survey through our SMS provider, Healthcare Communications UK. So our patients received a text message inviting them to participate in the study. And on following the link to the survey, patients received explanatory information which was embedded into the first page of the survey itself. And it was at this stage consent was gained from the patient to participate in the study. The survey asked patients to self-report a range of metrics, including demographics, rheumatic condition and management, COVID exposure, shielding status and shielding adherence. Patients were then asked to complete a validated health-related quality of life survey using the short form 12 questionnaire, which assesses physical and mental component scores on a 0 to 100 scale, with 0 being the lowest score. And data from each survey was collected 4 weeks following distribution, and comparative analysis was conducted between the 2 surveys using SPSS version 27. So on the 24th of April 2020, the 4-week point following the introduction of shielding measures in the UK, we distributed initial evaluations to the 7,911 active rheumatology follow-up patients at the Royal Wolverhampton Trust. And survey responses were received from 1,694 patients, that's 21.4%. And of these, we were able to link 1,636 responses to a validated mobile telephone number. 899 patients, or 55%, of the initial 1,636 patients responded to the second survey sent in December 2020. And of these 899 patients, 824 responses were linked across the two surveys and were used for the analysis. So of these 824 matched patients, 69.5% were female, and the patients had an average age of 61 years. 76.3% had an autoimmune rheumatic disease, and 388 patients were classed as clinically extremely vulnerable. And when comparing the health-related quality of life data across the time period between the shielding group and the comparator group, in the shielding group, physical component scores remained significantly lower than the comparator group, as shown in Figure 1 in the poster, with physical component scores in the shielding group versus the comparator group being 36.4 versus 39.6 respectively, with a p-value of less than 0.001 for survey 1 and 36.1 versus 38.67 with a p-value of less than 0.001 in survey 2. And as demonstrated in Figure 2, mental component scores also remain significantly lower in the shielding group compared to the comparator group, being 41.6 versus 43.4 respectively, with a p-value of less than 0.001 in survey 1, and 41.2 versus 43.6, with a significant p-value of less than 0.001 in survey 2. There was no significant deterioration in the shielding group score across the time period. As shown in Figure 3 of the poster, in the comparator group, the non-clinically extremely vulnerable group, physical component scores significantly decreased in patients with autoimmune rheumatic disease, with a mean difference in SF12 scores of 1.39 across the two surveys. Mental component scores did not significantly differ. So while mental and physical health scores were significantly lower in clinically extremely vulnerable patients, neither physical or mental health were worsened by the impacts of the pandemic over the 8-month period. And physical functioning of autoimmune rheumatic disease patients significantly decreased, potentially reflecting the reduction in physical activity faced by society and reduced contact with secondary care services. And these data suggest services need to adapt to provide additional support to maintain physical functioning in autoimmune rheumatic disease patients during the pandemic. And while we acknowledge that this study does carry limitations in that missing mobile numbers were seen across all age groups, which potentially introduces bias, and patients without smartphone or internet access are excluded, the strengths of this study are that it's an accepted method of communication in this population, which illustrates the potential role of this methodology during a public health emergency. The survey response rate is consistent with other surveys, and ethical approval has been granted, so further work exploring these findings is ongoing. This study shows that the wider impact of COVID-19 on patients with rheumatic disease is poorly understood, and baseline physical function in patients with rheumatic disease is known to be lower than the general populace. These data indicate that physical functioning in patients with autoimmune rheumatic disease has been significantly impacted by the pandemic, and more needs to be done to maintain physical functioning in this group, and further work is required to explore this data. So thank you very much for listening.